I'm lucky that I get to go to these lymphoma meetings, which I really enjoy because of the overlap with CLL. So we're going to move right now to CLL, back for a minute to the topic from yesterday. And you all heard about the ibrutinib yesterday. I'm just going to give you a little bit more detail today in terms of what actually has happened to these patients and the results that we've seen. And this is pretty updated. It was updated recently. So it's a little more updated than what you might have seen if you saw the presentation at ASCO. And these are my disclosures, both research support and consultancy. So you heard yesterday the sort of the rationale for why one might want to target the B-cell receptor inhibitor, and that's because when you ligate that receptor, you send a very strong survival and proliferative signal to the cell, whether it's a malignant or a normal B-cell. And so obviously if you could interrupt that signaling, that might have a laudatory effect in terms of trying to control the disease, which is, in fact is what we're seeing. And this is just, as you heard yesterday, one kinase that could be targeted in this pathway, the BTK, which is clearly a clinically relevant one because, in fact, people who are born with mutations in BTK have the disease, which is X-linked agammaglobulinemia, so showing the importance of this kinase in B-cell development. You also heard about ibrutinib, which is oral, and all of these drugs so far are oral. This one is highly potent, forms an irreversible cysteine bond, and is given once daily, so pretty easy. Now, initially you'll notice that when the study was first done, there were in fact two doses, 420 and 840. And the reason for this is that in the phase 1, there was actually an assay developed to look at occupancy of BTK. And it appeared that you had about 100% occupancy of the kinase at a dose that came out to roughly 420 milligrams, taking into account different body sizes, et cetera. And then when the trial was going forward, the company said, and I think reasonably, you know, are we sure that this is the only effect this drug has and that we want to stop there, and could there be other effects that maybe would be more beneficial at higher levels? So before we put all our eggs in one basket, let's do a second dose level, which we already knew we could get to without toxicity based on the phase 1. And so that's why you see 420 and 840. Now the data I'm going to show you is combined data, and the reason it's combined is, in fact, there was absolutely no difference in the response rates between the two doses, suggesting that, in fact, the occupancy assay was a very good rational way to pick the dose. When the treatment naive came on study, and that started a little bit later, once we knew how safe the drug was, the idea was again to have both doses, but because by then it had become pretty clear in the refractory that the two dose levels were the same, the 840 was closed. And that's why in the treatment naive over 65, you only see 4 people who were treated at that dose. And median follow-ups now are almost 2 years. Not 14 years like we talked about yesterday, but 2 years. 2 years is pretty good. So these are the patient characteristics, and I think the important thing to notice again is the deletion 17p, which we talked about yesterday as having a very poor prognosis with chemo, and being not that common in the upfront setting, which you see reflected here in the low percentage in the treatment naive, but very common, constituting a third of the patients in the refractory population. The other important point is that the median number of prior regimens in this population was 4, and you can see all the drugs that they had had. So this is the patient disposition. And what's interesting is with a median follow-up of 22 months, you see that the majority of people are still on drug. And so that's quite encouraging. More of the relapse refractory have come off because more of them have progressed. There's only that one patient we mentioned yesterday who progressed on the frontline study, and you can see that 10 people progressed so far in the relapse refractory study. Very rare to come off for AE. One patient came off for fatigue. I think one could question how much that was really the drug, but unusual to see a patient come off for toxicity with this drug. You heard yesterday the most common side effect is diarrhea. Tends to occur very early, and it's often self-limited. So sometimes people get it the first week they go on, and then it just goes away. And I would say of all the patients I have, only a few actually have to take medication. Most of them, they'll tell you, you know, I used to go once a day, now I go maybe twice a day, but it's not a big deal. Importantly, these drugs, and I refer to all the B-cell receptor inhibitors that in terms of idelalisib and some of the newer ones, don't seem to be myelosuppressive. And this is really huge in CLL because the biggest complication of treating this disease, partly because most of our therapies are chemo-based, is myelosuppression and infection, particularly that this is immune population without a normal immune system to begin with. So to have a drug that's not myelosuppressive is really, really encouraging. Now you notice that in the relapse refractory, we still have infections. And that's probably partly because they're very refractory, and even if you're not treating refractory patients, they get infections. But also I think speaks to the fact that I mentioned yesterday that I personally think it's important to get CRs. Because as long as you have circulating CLL cells, you are definitely having dysfunctional T cells and adding to the immune dysfunction. We mentioned that this interesting pattern of response, which you see whether they're refractory or treatment naive, which is that initially the lymphocyte count in fact goes up, and that's clearly related to changes in the chemokines that cause the cells to be released from the stroma. Now it's not quite that simple, because in fact the speed at which the lymph nodes shrink, if every single one of those cells was going into the bloodstream, we'd actually see lymphocyte counts much higher than we do. So there's got to be some kind of direct cell death occurring also, but I think the mechanism of that is maybe a little bit less clear than the compartment shift, which has been fairly well worked out now. So you see that the peak is relatively early. Again, the good news is most people can walk around with lymphocytosis with CLL without a problem. And then it starts to come down, but the lymph node shrinkage is very rapid right from the beginning. So this is the overall response rate, very high with both drugs. CRs are not common, as you see here. What's interesting is that even though the median follow-up is 22 months, so almost 2 years, there's still a small cohort in both groups where the lymphocyte count has probably come down from the peak, but by definition, it's not more than 50% below baseline, because then they would be a PR rather than a PR with lymphocytosis. So that in some people, there's really quite prolonged lymphocytosis. And the only thing that we've seen so far that predicts for that, interestingly, is being mutated. So when you think about prognostic factors, the mutated patients tend to have a better prognosis. Why would the unmutated be more sensitive? Well, interestingly, one of the reasons that the unmutated might be more sensitive is that they have much stronger signaling through the B-cell receptor, partly facilitated by ZAP70, which is present in about 75% of people who are unmutated. And so they may be more dependent on the B-cell receptor signaling, and thus when you interrupt it, they have a faster resolution of the lymphocytosis. The other very encouraging thing is that the drug works even in people with high-risk factors, older people who tolerate it very well. 17p deleted patients also have a fairly good response. And not only is it not myelosuppressive, but you see very dramatic improvements in cytopenias. And it's interesting, you can see the people, even I've seen patients becoming transfusion independent who went on transfusion dependent. Most of the time you can't even get those people on trials because most trials would exclude them based on severe cytopenia. What about immunoglobulins? There is the theoretical concern that as time goes on, because we're impacting B cells, that we may see an effect on immunoglobulin levels. With the follow-up so far, we don't see a decline in immunoglobulin levels. You see the IgG stays about the same, and if anything, there's a bit of an improvement in the A and the M. Now, again, we don't have 5-year follow-up with these agents, so what will happen in the really long term, we don't know. But so far, this is encouraging. And these are the progression-free and overall survival curve. Again, only one patient has progressed in the frontline setting, which makes that curve very impressive, but it's frontline. So I would argue actually that the relapse refractory curve is even more impressive to me, because with a median of 4 prior regimens, to have not reached a median PFS at 2 years is really kind of mind-boggling. Now, in fact, we are starting to see that some of the higher risk groups, like the 17p and the 11q, are not doing quite as well. But they're doing pretty well, and as I mentioned yesterday, that PFS curve for 17p is better than any frontline PFS curve for 17p, and it's better than any relapse survival curve for 17p. So again, you see the magnitude of these benefits. This is overall survival. So in conclusion, we see that ibrutinib is highly active. It produces durable responses. Durable, yesterday I was making fun of Jennifer a little bit for calling them durable at 2 years when we have FCR data at 12 years. But I think if we think about the population, relapse refractory, medium 4 prior regimens, then I think it's quite fair to use the word durable, which you would never see with any kind of chemo-based regimen in that population. It's extremely well tolerated. I'd say it's probably the easiest drug I've ever prescribed, even easier than the TKIs for CML that have more nonspecific side effects. It's effective even in high-risk groups, not myelosuppressive, and in fact improves cytopenias. Just to tell you where we are in terms of the development, the company has filed for approval based on the phase 2 data that I showed you in the relapse refractory population. However, they have some pivotal trials. Ibrutinib versus ofatumumab in relapse was designed for people who would not be good candidates for chemo. That trial has accrued and will have the first interim analysis at the end of this year. Ibrutinib versus chlorambucil, that trial is still open if people are interested in referring patients for it. It's all over the United States in patients 65 years or older. And then bendamustine and rituximab plus or minus ibrutinib, that was designed sort of for the counter population of the first trial I'm showing you, i.e. those who would be reasonably good candidates for chemotherapy in relapse. And then what I don't have here, because it's not randomized, is there is a 17P pivotal trial that was a single-arm trial in relapse. The idea being you wouldn't randomize because there's no good control in that population. And that trial has also reached accrual. And so I think you will see this drug through one of these various trials approved by certainly next year. So thank you for your attention.
Thank you, Dr. O'Brien.